Thank you. Um, Hopefully you can hear me. I have notes on my computer, so I thought that would be easier. First, I want to thank the Roundtable for the opportunity to be here, but also to serve on the Planning Committee. I think I learned a lot working with the Planning Committee, and I may have gotten a little bashing every now and then since I'm the clinical researcher. And wasn't using the terms around the health literacy terms as precisely as I needed to. So I appreciate the tolerance with me and the teaching me during that time. Thanks to Patty for summarizing lots of the things that I was going to say. I knew that was going to happen, so I'm really glad that you did. There are a few things I do want to point out, and then I'd like to share comments more from the standpoint of the clinical investigator and the clinical trialist, and what I see as opportunities, but also challenges if we're talking about doing a better job of integrating and embedding health literacy principles in this space. I really did appreciate a lot of the comments. They resonated with me as someone who spends a lot of time thinking about engagement as well as recruitment. A few points that stood out from the morning, thinking about sharing information in a way that is not biased. I think that was in Barbara's comments about how we sometimes will present the most important things from our standpoint as clinical trialists or clinicians. You have a 30% chance of your tumor shrinking by 10%, but we don't say the reverse of that, and so people are not really as informed as they need to be. And so I think there are aspects about health literacy, certainly well beyond the plain language that many of us in the clinical trial space don't really think enough about. I think the points that Deb made about being clear what's in it for the patient, what's the benefit to them, how we're sharing information, return of results. So I think some of those things are really a health literacy, require health literacy principles when we're doing that communication. I think the visualization piece, Katina talked a lot about that, gave some examples. These are, again, things that we don't really think as much about in general in clinical trial space. And then, of course, there are lots of great examples about how we can use these health literacy principles in specific trials, and I won't go into more details about them. The consent process is one that's obviously required for every trial. There's lots of variability in how these are done, and I think more opportunities for templates, tools, resources that can help trialists do a better job in their consent forms would be great. I think if you believe that every clinical trial has someone on the team that is good at communicating, you're wrong. I would say that most clinical trials don't have people on their team that are good at communicating. Some of them don't even have people who are good on their team at recruiting, which is why we have so many clinical trials that actually fail to meet their accrual goals. And that's just honestly why I have a job with the Recruitment Innovation Center. This is a center. I wanted to show just a few things that I think maybe will be helpful for you to know about. That certainly not all of the examples, this is our work, so I know more about it, but there are things that we are trying to do in clinical trials that have health literacy principles. Some of you might say it is actually a health literacy focus, but it's not terminology that we use because that's not the lens that we bring. So our Recruitment Innovation Center serves multi-site trials. It's part of the CTSA consortium, the Trial Innovation Network. These were funded about 3 years ago. Paul Harris, who some of you know, who created REDCap and Research Match, he and I lead this Recruitment Innovation Center. It's the only one in the Trial Innovation Network. There are 3 Trial Innovation Centers. As part of our Recruitment Innovation Center, we have a focus on minority recruitment, and I would say that's where a fair amount of our health literacy related work is happening. So we have a supplement that we call Faster Together. It's really intended to test different strategies for recruiting racial and ethnic minorities. One of those strategies is culturally tailoring materials. I will say we had a hard time finding actually information, checklists about how you go, what you do to tailor materials. So, we did an environmental scan, we did lots of things to make sure that we were capturing what was available, but I'm sure we missed things, and it would have been great if we didn't have to create these on our own, so we did. We just completed our minority recruitment training. That's the Coursera course that you see here. It is a mass online course. It's free, has 8 modules. It's intended to focus on help recruiters do a better job with minority recruitment. There are principles guided by input from minority groups included in there, how to communicate effectively, how to communicate with the intent of building relationships and trust. So a lot of the things that we talked about today. And then we also have, in the last year, a web chain. We have a version of Research Match that's now in Spanish. And that process gave Paul and others on our team a little bit of heartburn when I told them how this needed to work, that we couldn't just translate the website. He knew that we weren't going to use Google Translate, but we couldn't even just do a good translation service. We needed to actually lower the reading level first, and then do the translation. And so I think some people who live and do spend most of their time working with Research Match were a little offended by my recommendations for that. But the reality is, in the United States, people who are Spanish speaking and not bilingual typically have a lower reading level than average. So we needed to reduce the reading level to 4th grade before we even translated. And then we had an adjudication process and back and forth. And a lot of that, still we didn't have guidelines on how to do that. So I think these are things that the roundtable could help further. We also have some apps that we've created. Some of them are specific for patients, capturing data from them, allowing them to share information with the researchers. We also have a clinician app to share information. So the general tone of how we do our work is with disease agnostic, a focus of disease agnostic use. So some of the things, again, that you've talked about, we've started to create. I'm sure they could be better, but these are things that we can share, others are already using, and we could begin to embed some of those health literacy principles a little bit better. We have taken clinicaltrials.gov data, and we actually pull it every day. I say we, I don't do any of the informatics stuff, but we pull in from the NLM, all the clinicaltrials.gov data, and we put it through a more intuitive interface that's intended for the patients and the community members, even the clinicians. So you can actually search it based on your condition and gives you prompts to ask questions, and then it filters and brings it back the results to you based on how far where you want to look, based on where you live. We've had over 150,000 people use this. So from the standpoint of having individuals who want to participate in trials and are not waiting to be asked, they want to seek these, this is a tool that's available. What they get back is not in a health literate manner. So they get whatever is in clinicaltrials.gov. We can only change the interface for what they want to pull down. And then we are doing some work to try and embed trials within other trials, and so this is one where we did where we tailored for African Americans, and we have a control group control exposure at Vanderbilt and the tailored at Duke, and you can see the impressions. We don't yet know if that actually increased the recruitment yield or not, but so far, at least it's the clicks are better. So for us, you know, we're not really sure. You're just seeing the pictures there. We're not going to be able to tell if people are responding more to the images or to the fact that we reduce the reading level by 4 grades here. So I just wanted to give you a snapshot of that, and then I'll end just my quick rant of other things to think about. I do agree with Patty. We need more of a focus on general clinical trial awareness. No one is really owning that. I think certainly the NLM is involved in that, but there's very few people who are interested in things other than their own trials. The disease agnostic approach, I think you have to think about the value proposition for the clinical trialist. A lot of the things that I heard today are going to require time, resources. Where is the money coming from? Where is the training coming from? How are you going to actually show that this is a benefit? And I think to do that, you're going to have measures and metrics that matter to them. And so if you're going to recommend things like communication plans, we need to know that that's actually been implemented, how long it takes, what the resources are, or else you're not going to have very much uptake. Thank you.